I'd like to introduce our next speaker, Dr. Neil Alexander, who is back by popular demand. He has spoken at several health days over the years. Dr. Alexander is a graduate of the University of Minnesota Medical School and also received a master's degree in clinical research design and biostatistics from the University of Michigan. He completed his internal medicine residency at the University of New Mexico and a geriatrics fellowship at the University of Michigan. He is board certified in both internal medicine and geriatrics and is the Ivan Duff Professor of Geriatric and Palliative Care Medicine. He is currently the Director of Geriatric and Research Education and Clinical Center at the Ann Arbor VA. Dr. Alexander is nationally and internationally known for his innovative research in mobility assessment and interventions, gait, falls in older adults, which are all topics relevant to everyone here. We're privileged to have him here today. He has a clinic coming up and he needs to leave promptly at noon. We discussed the possibility of having him remotely, but he graciously agreed to come out here, but has to leave at noon. So now please help me welcome Dr. Neil Alexander.
Thanks for the opportunity to come back here. Does anybody remember me from a previous lecture or previous time? Do you remember me when I walked in with shorts? And because I went to the wrong place initially, and then they said, everybody, why don't you lecture in shorts? And I refused to, and I came back in real clothes. Yeah, that was a great one. I'm going to say a couple things. First of all, I'm going to try to get as much as I can in for the next 3 hours. Oh, I'm sorry, next hour. And I want to give you a chance for questions, but I'm never going to be able to answer all your questions, and I can't stick around. But I'll give you two things. Just remember, at the end, there's going to be a shameless plug for my clinic, which actually is going to go on today, and I don't want to be late for my patients, even though I sometimes am. And then a shameless plug for an article that came out in 2017, which basically summarizes just about everything I'm saying. So if you don't think you got it, there's some resources at the end. Do they have access to the slides? They can? Okay. I may want to sanitize some of them, but I think they're generally okay. Okay. Right. So I'm going to talk the general talk outline, and this is a talk that I give to medical people, and I think a number of you are actually medical, nursing, health professionals, specialists, so I think you'll probably get what I'm doing. Some people will not. I'll try to keep it as much in real language as I can. First, that's kind of our talk outline. Let's start with epidemiology and key concepts. I'm going to be looking for the neck. You know when you fall asleep? And I'm also the last thing between you and lunch, so I get it. Okay, totally get it. Okay, so you may or may not know these numbers, but it's pretty striking. About a third of U.S. residents age 65 and older fall each year, particularly those who are 80 and over. Nursing home residents, it's a big issue. 1/5 of falls cause a serious injury, such as broken bones or head injury. By the way, I added head injury because that's kind of an emerging area that we're starting to look at in terms of research. Our group is for sure. Complications of falls are the leading cause of death from injury. That's a big one. So keep that in mind. As if you're not fearful enough about falls, I just made you more fearful. But the total medical cost this is a number from 2015, and I actually couldn't find anything newer. It's probably that's a way underestimate. Most of you probably worried about hip fracture, right? Remember I said broken bones and head? So most people are worried about hip fracture, and it happens about 1% to 2% of falls, but look at all the other things that happen to people. People bang themselves up and break other things. And then inability to get up after a fall, fear of falling, and decreased activity, that's the real problem. In addition to the injury, things happen to you afterwards, you don't feel like you can do stuff you used to do. What is a fall? And we actually argue about this. Let's keep it simple. Unexpectedly lower to the ground or lower level excludes loss of consciousness. So if I had a patient last week in my clinic, they were having syncope, meaning loss of consciousness. I said, you're in the wrong clinic. That's not what I do. So I'm excluding that, or some sort of overwhelming event, such like if somebody pushed you or hit you. That's also the wrong clinic. Okay? I want you to get the idea that it's an interaction of multiple factors. So there's extrinsic, that's out in the environment. This is what you're most worried about, the slip, the trip, on an icy surface, on a curb. Most of you, some of you, have some intrinsic factors. You're a little older, you're a little weaker, you have more joint pain, you don't see as well. Intrinsic, of the body, out in the environment. And they act together in certain situations. And that's what I'll get to in a moment. Okay? As you might expect, people who are more disabled have more intrinsic factors, and people who are more extrinsic factors and more independent, these are what I call the free-range older adults. I made that up, and I'd never seen it written anywhere. So what are these intrinsic factors? So you think, oh my God, I'm old, I'm going to have all these intrinsic factors. I put them into central processing, that's brain, vision, inner ear, vestibular, some other systemic, musculoskeletal, neurological issues. I have to say that your age, this is a key thing for geriatrics. What happens to you when you get older is age associated. It may be age caused, but it's age associated. In other words, as you get older, I have to say into your 80s particularly, you start to get stuff. You start to notice stuff. Maybe you noticed it earlier. And that's what I call age-associated diseases. And this is kind of the take-home message for geriatricians. That and a lot of people, I'm in this group, I think, are aging what we call successfully. But the ones who are aging more normally may have these diseases. It's a central processing problem. This is dementia, visual changes, cataracts, macular degeneration. That's ARMD, glaucoma. You know, we're doing a lot of work in inner ear now. I don't think that's really a disease of aging, but we see it periodically. Not necessarily just older adults. We see a lot of systemic problems. Like somebody has a kidney infection or heart failure or a thyroid problem, it may manifest as a fall. So I'm always on the alert for that. Actually, when it stop for a second, have you ever heard of orthostatic hypotension?
Yes.
That's when your blood pressure drops too fast when you get up. And everybody here sits, including myself, sit on the edge of the bed to wait till you normalize. That's another whole lecture, which is a very interesting area. But that's not necessarily just a disease. That actually could be also part of older adults because their arteries get thicker and less distensible. There's your word for the day, less distensible. I think what we've forgotten is that the fact that a lot of us have old arthritis. I'm saying us, myself included, and the joints don't respond as well, particularly when you try to recover from what we call LOBs. That's different from SOB. By the way, SOB in medical parlance is short of breath, for those of you who know. But I know you were thinking something else, weren't you? Loss of balance is LOBs. We call it. And so a recovered LOB is what we're very interested in. And an unrecovered LOB is a... wow, you guys are right on. Very good. Anyway. Notice at the bottom of the list, I put all the neurological... By the way, can everybody hear me okay?
Yeah.
That's amazing. That's not possible. Okay, so things like I'm looking in my clinic for Parkinson's, I'm looking for myelopathy, like a spinal cord problem, I'm looking for stroke, PN is peripheral neuropathy. But that's at the bottom of the list. There's a bunch of other things I'm looking for too that contribute to falls, okay? All right. Look familiar? Hopefully not. This was collected from a social work visit to a patient about 20, 30 years ago, actually, from Turner Clinic, one of the Turner Clinic social workers. They said, I have to have a picture of this. It represents polypharmacy, which is a big deal. Medications have an interesting impact on falls. Ones that affect reduced alertness or retard central processing. These are the analgesics, like medications, painkillers rather. Psychotropics, like benzodiazepines, like Valium, which I hope few people are taking up in this room. Actually, benzodiazepines can be dangerous in older people, so be careful with that one. Phenothiazines are the antipsychotics. Tricyclics, the antidepressants we don't use so much anymore. Some of you are on SSRIs, the typical antidepressants, so don't walk out of here and throw them in the trash, okay? They have been associated with falls, but particularly in the acute titration period, when you're starting them up. So there's data on it. I can't lie. But some people, actually there was a study in New Zealand. That they, New Zealand or Australia? Sorry, I don't know. I know the difference. Where they took away all the meds and they exercised them and they dropped the fall risk. The falls went down. But guess what happened at the end of the study? Almost 50% of the people want their meds back because they took their meds for depression, anxiety, hallucinations, psychosis. So it's an imperfect solution. Anyway, anything that impairs cerebral perfusion is the next area. That would be something like a blood pressure pill or a diuretic. Those happen particularly when you're not drinking enough or when you get sick and you keep taking your meds and you get in trouble with that. These other ones, direct vestibular toxicity, we don't see so much anymore. And occasionally I'll see people on medications that cause extrapyramidal effects, which means Parkinsonism. So, am I making sense already? Am I too medicalese? Trying not to. This is Alexander's Hall of Falls. So these are called the extrinsic causes that I'll talk about. There's a shadow there. There's a wire. There's clutter. There's I don't know who would put a sofa there and to access the light switch, etc. You get the idea. This has been a difficult. Initially, years ago, we'd send people into the home with checklists like, pick up your rugs, do this, do that. It's difficult to prove that works, but I think the data now suggests that it does work. But it's only, some people want that terrible old saggy chair that they have trouble getting out of. They just want it, and they're aware of all the clutter in their house, and they just want it. So it's a little difficult to prove that it makes a difference, but in general, we think it's important to work on the extrinsic causes. Now the situational factor example. So the intrinsic and extrinsic working together, you collide with something in the dark. What's the answer to that one? Turn the light on. Or night lights. Oh, I get the light from the street in my house. Well, actually, I think that works. People tell me that all the time. Changes in friction between the shoe and different flooring. We don't have linoleum, or I'm not sure if that's the right term anymore, but there's between linoleum, or there's thresholds, door thresholds when you walk in here. So that happens. This is a good one. Failing to recognize temporarily hazard situations. You're kind of hanging out, you're walking along, you're not paying attention. That's a big deal. We think that that's probably one of the frontiers of fall risk reduction, is being more attentive. Easy to say, harder to do. Or preoccupation, distraction by another task. You probably are told not to drive with your phone, right? Well, actually, you can't drive. It's illegal now. You have to be careful when you walk with your phone. Okay? No, I'm very serious. There's lots of that. Inappropriate behavior in potentially hazardous environment, hurrying too much. Okay? Somebody here has fallen from one of these factors, I'm sure. Activity that results in a displaced center of gravity, like pulling the drawer too hard, sudden acceleration, being pushed or hit. I told you we're not going to look at that. Carrying a heavy object, especially in front of you. I tell people, don't do that. You need your hand. Your hand is supposed to. Some of you probably use. Again, I don't want to tip. I don't want to be ageist here, but somebody here must be using their hand for furniture surfing. Furniture surfing, right? Touching the wall, touching the sofa. We call it furniture surfing. Actually, one of my patients came in and said, "I furniture surf." I said, "Where did you read that from?" And then assuming an unusual position or motion, like doing a sport activity. Okay. So some of you, when you go into, God forbid you have a fall and you go into the emergency room and they say you've had a mechanical fall. Have I talked about mechanical falls yet? Will I talk about mechanical falls? Well, you can tell by just slash through. Because it's really, it's a slip or a trip, really, over something in the environment. But remember, I told you, it's not just the environment, it's who you are and your ability to deal with the environmental demand. So if anybody tells you you had a mechanical fall in the ER, tell them, Dr. Alexander told you you're wrong. I didn't. Actually, when I have residents and fellows in my clinic, that's what I tell them, don't use that. Okay. Risk factors for falling among community living older adults. Now this is from the epidemiology, this is from the literature. Of interest, obviously when you get older, I remember this is age associated maybe, Cognitive impairment is a huge one that we've been working on for years. I don't know what to make of the female gender. I think it has to do with a cohort effect. Women in their 80s and 90s may not have exercised or be as vigorous in their ability to respond to a fall, maybe. Hypovitaminosis, like low vitamin D, is less of an issue nowadays because it's so controversial about vitamin D supplementation. Foot disorders, everybody in my clinic takes their shoes off, and I look at their feet. Yeah. Balance problems, of course, psychotropic meds I mentioned, pain. I mentioned about the arthritis piece, Parkinson's, stroke, and arthritis. And the risk of falling increases with a number of risk factors. Okay. So this one, I glossed right through that. The most important risk factor for a future fall is a past fall. What did they say? Past performance is not indicative of future performance for stocks. It's true for falls. Past performance is indicative of future performance. So accordingly, now the hot issue now, we ran a large national study where actually University of Michigan was a major player. I was the site PI for the University of Michigan to reduce fall injury. Isn't that really what it's about? I mean, you want to reduce falls, but you really want to reduce falls injury. Well, how do you do that? Not with what we did. We tried to reduce falls. And I think what we missed the point is that we need to reduce the factors that cause injury. And in this case, this is a cartoon that shows the conditions necessary for fall result in a hip fracture. So which one of these is women is going to break their hip? This one on the left or this one on the right? Ignore the stairs. Not sure, huh? Look what the one on the left is doing. She's got her hand outstretched. She's probably going to break her wrist. She's got a wide base of support. She's going like this. This one, pardon my cultural heritage, is doing what I call the oi response. Oi! Instead of having her arms out, legs out, and do some sort of important, what we call reactive balance response, and look at her feet. She's going down. And they actually do, what they often do is they do an anterolateral rotation, and guess where they land? On their hip. So that's what this cartoon means. That's when you land on a hard surface, which this is pretty hard actually, and you land right on the hip. That's what that means. This means those of us who don't have enough padding, I have a little bit of padding, I have more than a little bit of padding. If I land on my butt, I'm safer. That's what that means. But unfortunately, that's not all, I can't always do that. This one here represents bone strength. That's what your doctors do. You walk in the door, they said, let's work on your bone. Don't you want to work on my fall risk? No, I don't know how to do that, but I want to work on your bone strength. So there's actually a clinic at the University of Michigan, shameless plug maybe, the Bone Fragility Clinic. And they said to me about probably 20 years ago, they said, how do I teach people about fall? They said, just do bone. You do bone, I'll do falls. And so they've been referring to me for a number of years already. And that's what, so there's nothing wrong with building bone, it helps, but it's only one of many factors, I think, if I can convince you that. And I may have data here, this is old data, but if you fall to one side, the risk of a hip fracture is highest if you have thin bone mineral density. Potential energy means how high you are, not with marijuana, but how high you are in this crowd, you know? So, and body mass index is how much muscle and fat you have. So really it's an important issue. Okay, what's the fall risk evaluation? Okay, this is going to be a little medical. And rising from a lying or sitting position, they tell me I feel like I'm going to fall down. I think about orthostatic blood pressure. Whoa, that was fast. Or something called benign paroxysmal vertigo, where you had your head in certain positions, you're dizzy. I see patients like that. I send them to my healers at the Med Inn. They have a vestibular clinic. There are other vestibular experts in this Michigan medicine system, but I have my own. I just divulged my source. Sorry. But anyway, that can be fixed, even in advanced age. Trip or slip doesn't. It could be anything. It could be like balance, gait, vision, something like that. After coughing or urinating and have a recent meal, you You might tend to pool your blood in the middle of your body away from your head. Not so common, more like nursing home patients. Looking up or sideways could be related to a TIA, like a mini stroke. It could be related to vestibular problems. There is a literature, and you may hear about it, that if you wear a tight collar and it massages your carotid body and your artery, it makes you fall down. Don't even go there. Don't go there. Well, first of all, don't have a tight collar. But don't go there because no doctor in the United States is going to massage on your thingy, and they're going to hook you up to a monitor and give you some medication to make sure you don't bradycardic out. This is Ireland, or this is English data, and I once spoke at a conference for this person, the PI of that, and she was not happy about that. But it's basically you can recruit a lot of people, and some of them get better with a pacemaker, but not many. So anyway, too much time on that one. I don't think people ask about arthritis with your leg catches or gives out or is unstable. I think it's a real thing. And it probably has to do with that pain thing I showed you. Dizziness. So I think people struggle with dizziness and how to describe that to a physician. The simplest one is that if you're moving or your surrounds are moving, there's a sense of motion, that's probably vertigo. Everything else is something else, like dizziness-like. And so that's the challenge. It turns out that there are certain exercises. Anybody here do these eye exercises, head exercises? Oof. And it makes you a little dizzy. Doctor makes, say, doc, it makes me dizzy when I do that. Well, do that because it habituates you. And even if you don't have, I've convinced my vestibular specialist that doing those exercises for these people who I think have a motion-provoked, like vertigo, they get better doing these eye exercises and head exercises. Did I go through that too fast? No? Anyone get dizzy when they went like this? Okay. All right. So I mentioned vertigo. Everything else could be, we call it presyncope with orthostatic, a dysrhythmia, a rhythmia problem, or anemia, and other things. There's a bunch of things that make people feel dizzy, but the important thing is to make sure if you have a motion-provoked vertigo, I think that can be fixed. Okay. Examination. Mental state. I mentioned cognitive impairment. I want to know how your brain's working because I think people make bad decisions or are not paying attention, and it may be an early sign of cognitive impairment, like dementia. Orthostatic blood pressure and pulse. How many people have had their orthostatic blood pressure checked? Okay. If you've been checked, I'm sure I have some nursing faculty here somewhere or nursing people here. You've been taught in nursing probably to do a lying and a sitting. The main reason is because if you stand them up, they fall down, which is not good when you're on a nursing floor. Okay. On the other hand, the definition is to have them stand up. Okay. So if your doctor checks your blood pressure lying, that's fine, or sitting, that's fine. But the real trick of orthostatic blood pressure and falls is standing up. This is a maneuver where I put your head to the side and I put you over the edge of a table, and it's pretty dramatic when it works. People who have kyphosis, you know who you are. It's hard to do that, so I often have them go to the vestibular specialist, the PT, and they actually have special tables that go downward. But then I can elicit inner ear vertigo. Vision screen, listen to their heart, cardiac massage, no. Looking at their joints and feet, there's a lot going on in the neck and spine. Even if you've had surgery, like lumbar stenosis or laminectomies, or cervical stenosis is kind of like a Wild West to me. So I find these patients, or they've done one leg, like you've replaced one leg. They don't replace a leg. They replaced one hip. What about the other one? So that's kind of the things I'm looking for. I think it's been underestimated in terms of fall evaluation. Neurologic exam, I'm looking for strength and tone. I'll get this kind of ratchety thing if you have Parkinson's, which is a tremor, a shaking tremor equivalent. I have their shoes off, right? I'm wiggling their toe. If they can feel me wiggling their toe. Some of you had a monofilament, a little nylon thing that they stick under your foot to see if you can feel it. So I'm looking for sensation, because remember I said peripheral neuropathy is an important piece. And then I look at stationing gaits, something called the Romberg. That was good. So this is, I don't know if you can see me, I have my feet together. Okay? If they can't do this with their eyes open, what's wrong with them? They're a mess. Okay? Okay. But if they can do it with their feet together, eyes open, then guess what I have them do? Very good. So I have them close their eyes. Now they're dependent on what two systems? Ooh, good. At the feet, proprioception. And where else? I go like this. The inner ear, the semicircular canal. That doesn't mean you're crazy. It's the semicircular canals. So this is a good test. If people can do this for 30 seconds with their eyes closed, I think that their inner ear and their feet are okay. Not great. They could have a problem, but they're okay. Then I have the people who are the worried well, whose tennis game is not as good as it used to be. And so I have them do a one-legged standing, like so. Using the wrong leg. I just injured this leg. So notice I'm not storking or flamingoing. My foot's out here. And if you can do that for 30 seconds, you're pretty darn good, especially both legs. Now I have less than 5 seconds because we know that's a risk for fall injury. So that is balance testing 101. And I have a gait testing 101 slide to show you. Who's got the abnormal walking? The one on the left or the one on the right? So you agree on that one. What do you notice of the guy on the left or person on the left? Shorter stride length, yep. Leans forward. Shout. Lack of arm movement, very good. What's that?
Arms close to the body.
Arms close to the body, yep. Is that, for those who have a medical or health background, what does that remind you of? Parkinson's. Oh boy, it's a good crowd. So it turns out, look at the date there, 1969. This is a composite of a young person, a composite. In those days, they allowed you to get away with that when you published papers. No longer. This is a composite of a young person. This is a composite of a healthy old person. None of you, maybe some of you, but virtually none of you walk like that. So it was clearly an ageist kind of drawing, but you can tell when someone has a walking problem. I proved this to the residents and the fellows. They have when they come into my clinic, they have no clue what to do with this. But they can identify there's something wrong with their walking. And once they do that, well, they can come talk to me. And that's my job, to figure out what's going on. And usually what's going on for walking problems, I just want to show you, you don't have to know all these diagnoses. You see there's a bunch of diagnoses that are under the neurology clinic, not in primary care, but they have things like DJD, which is arthritis. I don't even know what senile gait. I don't think nobody uses that anymore. And they have multiple problems. 75% of them have multiple combined. The point is, when there's a walking problem, if you have a walking problem, it does not necessarily mean that you have a neurologic problem. And that's kind of been eye-opening. I wrote my first review on gait disorders almost 30 years ago, I'm afraid to say, and that was one of the conclusions. And this is kind of a classification scheme. Again, this is pretty medicalese, but things that are in motor, that are in the arms and legs, a muscle part, joint and muscle, sensory, are kind of the peripheral low level. And move it all up into the middle level of the brain where you see stroke, cerebellar, Parkinson's. This is kind of a very interesting area, and we see this in people with frontal or white matter lesions. If people have strokes, dementia, they kind of walk stooped over and short-stepped, and you think, oh, maybe all of them have Parkinson's. Not necessarily. This high-level cortical meaning the brain substance disorder, I consider in clinic. Okay. Evaluation, CDC, I think this is still live. They call it STEADY, Stopping Elderly Accidents, Deaths, and Injuries. You should know this. Have you fallen in the past year? You might see that now around the country as being asked as a quality measure for care, for primary care. Do you feel unsteady while standing or walking? Okay, I'm sure a number of us probably feel that way. And they worry about falling. Who does not worry about falling here? So it's kind of a dumb question, and I told them so. Wait, somebody raised their hand. You don't worry about falling? Oh, okay, well, I have something for you that you'll never worry about falling again. Remind me if I forget to tell you. Okay? No, what I'm talking about is training people to fall. We've been doing that now. Anyway, so this is what we have. I don't necessarily use that last question. I don't really believe that anyone has a no on that. So what I do is I do some sort of gait strength or balance test, which is basically get out of a chair, timed up and go. Get out of a chair, walk. That's probably 8 feet, and turn around and go back, or 10 feet. Okay? Most of you can do that, otherwise you wouldn't be able to get here today. And the ones who are more than 12 seconds are at risk for something to go wrong. And from that, if you don't have any falls, we just do things like education, review meds. What I want to show you is this one. This one here. If somebody's had 2 or more falls or an injury with a fall, that's the multifactorial. Those are the people that need to be referred to my clinic for a risk assessment. Maybe your primary doctor can do it, but probably not. Your primary doctor is likely going to send you to the PT, which is okay, but that's not really what the state of the art is. And unfortunately, there's not a lot of me. And there are some geriatricians who are good at this. I'm a geriatrician. I take care of older adults. We develop individualized fall risk interventions and review the plan. Okay. Remember I talked about all these factors already? I didn't talk so much about feet and footwear. There are a lot of people with toe deformities and toes that don't work. What's the best footwear? So something with I'm not sure I have a slide on this. Well, I'll say it now. Has to fit well. Has to have the heel is covered. My shoe covers my heel. Like slippers, negative. I've had people come in clogs, negative. Okay? Low heel, so no high heels, especially for you guys. And non-skid sole. They have these SAS footwear. I think that's fine. I think sometimes they're a little grippy. So maybe there could be too much grip, especially when you change surface. I don't want you to throw away your SASs, and just be aware that sometimes they're a little grippy on certain surfaces. Okay, that's footwear. Okay, what's the lab workup? I don't know. Does that look familiar? Blood tests, CT scans, all that stuff? No one really knows how to work these up. What they'll do in the emergency room after you've had a fall and you've hurt yourself, they'll say, they'll CYA. They'll cover that's CT. You know what I'm saying? So, but you're looking for stuff. You're looking for some sort of, mostly they're looking for some sort of bleeding or some sort of trauma in your head. But I'm looking for something, this is what I'm often looking for, is some sort of, not necessarily a tumor, but infarct, some sort of stroke. And often I see what's called white matter changes. Anybody have white matter changes in their CT or MRI? You do. A number of you do, I'm sure. In the old days, the radiologists used to say, you ready for this? You're going to love this. Normal for age. What the hell? No, it's not. What's normal for age? Anything is normal for age. So it turns out that a number of us, some really outstanding investigators, have actually found linked walking problems and balance problems to these white matter changes in the right spot. Guess what else it's linked to? Not just white matter changes, are linked to walking problems and thinking problems. Yes, exactly. Somebody walks into my clinic, has a thinking problem and a walking problem. I'm thinking, some sort of vascular issue. Boom. Never did that before. Fall risk interventions in the community. Okay, so we did these risk factors. Now we're going to do we're going to intervene multifactorially. We teach them stuff. We minimize their meds. That's standard geriatrics. We exercise. I'll talk about that in a moment. We treat vision. By the way, if I fix one of your cataracts, now a lot of you go to your eye doctors and they say, well, we have immature. Your cataracts are immature. I think the ophthalmologist may be immature, but anyway, the cataracts are immature. It turns out that you fix one cataract that, well, let's presume it's mature, you can reduce your fall risk. Randomized control study, data, evidence-based. Yeah, Vitamin D, I don't know what to do with that. Pacemaker, postural hypotension, foot and footwear we talked about. Oh, this is an interesting one. So those of you who know me, I work at the VA. I'm director of center of the VA called the GREC, which rhymes with the Yiddish word which is Drek. People know what Drek is? Maybe I'm not going to go there. Thank you. That's good. That's a good translation. Anyway, GREC. No, no casting aspersions. It's an outstanding center, and we run these what are called clinical demonstration projects. One of them we have a tele-OT, tele-occupational therapy. And this is kind of what we do. And this is all remote, by the way. It's all doing virtual, and the VA has been out in the front of virtual care. So I have some healthcare worker, and in my case, an OT who actually does what we call HSEs, home safety eval. To my knowledge, Medicare does not cover home safety evals. You have to kind of buy into the home care, which means you have to be homebound. Anybody here homebound? No. That's why you're here. You're not homebound. Okay, so other thing is treat underlying diseases, and I mentioned that briefly earlier. I want to call your attention to bait and gallance disorder. Think about that one for a minute. PT, exercise, that we'll talk about in a minute, modalities, but assisted device use. You're not going to walk out of my clinic without a discussion about a cane or a walker, a walking stick, a furniture surf, something. Okay, something. And we have a stigma about using these, right? It makes us look old. So maybe we don't want to look. Maybe we don't want to look old. We want to be safe, don't we? Okay, there you go. Dizziness we talked about briefly about the training, about the eye movements, and cognitive loss is a different lecture, but I think that's a big issue. Foot problem. Oh, here's the foot word thing here. We got it. Okay. Vision, we talked about lens correction. You know, there's a literature on people who wear bifocals and trifocals that are at higher risk for falls because they're, where are you looking? And so when we ran our national study, the vision people said, oh no, you got to change everybody out from bifocals and trifocals. So they have to have regular distance glasses and reading glasses. Yeah? How well do you think that worked? Not. So it's still an issue. I don't think it's a big issue, but it is an issue. Osteoporosis, we talked about bone strength. That's a different lecture. A low BMI, if your weight loss is an issue. By the way, we have a clinic called the Owl Clinic, as in owl, but it's misspelled. It's optimal, health, weight, and lifestyle. OHWL. Do you hear the word weight loss in there? Negative. So we have a kind of a brilliant young faculty member. Her name is Shen Duar, and she's taking people well into their 80s who have obesity, BMIs of 42 or more, and she's seeing them. Now the thing is, now she's starting to give them these supplements. And what do you think happens when you lose weight on these supplements? You lose weight. What are you losing? Muscle and bone mass also. It's a big problem. It may not be as much of a problem for 30 and 40-year-olds who shouldn't be getting the medication anyway. Maybe they should. But so we're still trying to struggle with that. And so low BMI and weight loss is an issue for falls as well, mostly because of muscle mass loss. And then medications is a separate lecture. Eliminate meds, lower the dose, short acting, etc. Okay. Anybody here do Tai Chi? Bad Tai Chi? Okay, bad Tai Chi. In terms of an alternative, integrative exercise in the community, it's the one that has the most data that supports it. I personally am a yogi. I do yoga all the time. I think it's just as good, but the data is not as strong as with Tai Chi. Okay, what are best practices for exercise? What should you be doing for exercise? Moderate to high balance challenge. Don't just sit there and stand. Do something. Change your balance, base of support, move around. You have to have a sufficient dose. 2 hours per week for 6 months for 50 hours total is an example. You got to be dedicated to this. I'm just talking about, and you'll see in a minute what. You have to keep doing it. You know the term use it or lose it? Especially for older people. So there was a study in the mid-90s where they took nursing home patients who were very, 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 very weak, and they made them very, 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 very weak. So, and as soon as they stopped, they went back to very, 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 very weak. So you got to keep going. Target general community as well. Group is okay. You can still do a group, but home base is especially effective. Okay. Walking or strength training as an adjunct, but it's not the only thing. Though many of you walk, great. It has a lot of benefits, but you need more for fall reduction. You probably need some strength and some balance training, which is what I was getting to up here. And the list of recommended programs in Southeast Michigan, I'm not sure, is anyone taking Otago? I don't think they even have it here. They have a matter of balance. Anybody do that? Matter of balance is really not so much an exercise program. It's more kind of like get your head straight about fall risk and your self-efficacy. But Tai Chi is the one that people recommend. Again, I think there's many, many ways to do this. Some of you might have a trainer, which is a little expensive, but they can get you to do strength and balance exercises. And I mean, not just, and one of them would be one-legged standing. I'm gonna use my other leg. One-legged standing. Okay. These are some of the data. I'll quickly show you that if you do a multifactorial assessment intervention, like I told you, you reduce fall risk by 21%. Grade C. So the USPSTF, they don't like anything. So they graded C. Exercise, some reduction in a grade B. Vitamin D, we don't know. The point I'm trying to make here is that you're not going to stop falls by just exercising and just doing everything I told you. You're going to decrease your risk. That's the goal. You still got to be very, very attentive. I can't see this. Oh, here's interventions. Oh, this is a newer version. Muscle strength and balance I mentioned. Tai Chi, home measured assessment. Okay, so this is from AGS, American Geriatric Society syllabus. So they tend to be a little more wonky about this. Sorry if you can't see this very well, but everything I told you can try. Vitamin D, we don't know if it works. Maybe for people with vitamin D deficiency, first cataract surgery. I think I covered most of this stuff already. Okay. I'm calling out this study, which is 20 years old now, that they had people who had fallen the last year and are concerned about falling. They had a home OT class, they had weekly classes, and they had exercises as well, and they reduced their falls remarkably. This is just one study. I'm not trying to undermine, but I'm saying that I think there's something to be said for in-home behavioral-based training, which is something we're very interested in doing. And this is one way to think about this. This has actually been adopted in the hospitals. Michigan Medicine has adopted this color idea, where you use a balanced confidence scale to figure out the activity that's restricted. So like, if it's a red activity, you're going to lose your balance, don't do it. If it's a green activity, you're unlikely to lose your balance, okay to do it. Yellow, it tends to be a focus of training. And the yellow light example would be walking on stairs. It's definitely a yellow test. When you do it, when you're not fatigued, how? Walk step to step, use the railings, where it's well lit and edge contrast. Moving mindfully. Remember that. Move mindfully. What are things happening in these care facilities? So I'm not going to spend a lot of time on this. I think it's very difficult to disentangle what's going on. We spent a lot of time on this. I was just on a call for the National VA about this, and it's unclear that we can do anything with people with severe dementia, and it's more like kind of surveillance type of thing. Exercise maybe is subacute, meaning that they're hanging out in a post-acute unit. It should be used post-acute, not subacute unit. You have a few weeks to work with people, maybe that helps, but it's still unclear. So here's what AGS says. It says, many risk assessments have reasonable sensitivity and specificity to be valued. Multifactorial interventions that target individuals' greatest risk for falls, including a plan that uses HIT, Health Information Technology, has been effective at reducing falls. So they're a little bit more sanguine about what we do in a hospital, and I don't think it's relevant for you guys here today. And then nursing home, nothing's really working very, very well. Okay. At University of Michigan, we had this tool called the FRAT. Not fraternity, but FRAT, fall risk assessment tool. We got rid of it. So basically we have universal precautions for all, and we assess for risk factors every 24 hours. We use what's called the Morse scale, and we're looking at these aspects: falls, mental status, elimination, that's bowel and bladder. And this is what it looks like, and these are the interventions. I want to call your attention to proactive toileting. Try to take people to the bathroom or try to remind them to go to the bathroom. And it has a mixed benefit. So you wake up some people in the middle of the night, you should go to the bathroom. So they say, no, I don't need to go. An hour later, they get up, you know what, maybe I do need to go. And they get up on their own. You can imagine what happens. This one is an interesting one. I think there's a national study going on at University of Michigan, right, at Michigan Medicine Hospital, where people aren't thinking right, they have delirium, we call it. And so you try to do everything you can to make them not have delirium. And there's all kinds of things we do for a sleep-wake protocol, minimize contributors to delirium. And then the last one is disrupting vision, hearing, and having dizziness. So best thing you can do for particularly somebody who's cognitively impaired, get your hearing aids on, get your glasses on, so at least you can interact safely with the environment as best you can. Oh, this is a version. I don't know if it's the latest one because they're getting rid of it, I think now. But this is what we started with at the University Hospital. You're not safe. You need help. You can go on your own. And here's these other. Remember these risk factors. You've seen them before. Proactive toileting. I mentioned glasses, hearing aids. Do not leave me alone in the bathroom. Oof. People want to do their potty on their own, and that doesn't always work safely. And speaking of potty, these are universal fall precautions that all patients, you're sick enough to get into the hospital, you're sick enough to fall down. Okay, good, thank you. So these are the 5 Ps: pain, potty, position. Somebody's a nurse here, must know what the Ps are for this. But this is, you can stop falls. The nurses are going to love this. I'm a font, by the way, friend of nurse and therapist. Good nursing is really what's attentive nursing can really do a lot to reduce falls. It's not high tech. There's some sacred cows, physical restraints, and restrictive bed rails. Tie them up. No, doesn't work. Use a sitter. No, it doesn't work. They have to. Low beds and floor mats. Doesn't work. Bed alarms. We still do them. Doesn't work. Let me restate that. These work in isolated cases if you know how to apply them and your staff uses them properly. But in general, the evidence suggests they don't work. And the delirium prevention, I think, works, and that's what I just talked about. So falls can be reduced, but not absolutely prevented. I mentioned that. Associated with comorbidity and disability, not just age. Evidence-based interventions vary in quality. What works in the community may not work elsewhere. I talked about that briefly. Consider risk for injury. All hospital risk, universal coverage for all, customized plan for some, plan of care using individual risk factors. And this is our biggest challenge right now, cognitive and behavioral risk factors. What are we going to do for people who are confused, not pay attention? And we're still working on that. Future directions. That's what we're doing. I'm serious. We got money from the National Institute of Aging to do a study on, and it's actually centered in Kansas. We're going to bring it up here if we can. Well, we will bring it up here. It's a tuck and roll. We've got a group of people doing it, older people. I wouldn't say they're frail. The mean age, whatever that means, the mean age is probably in their 70s, low 70s, and they're tucking and rolling. So it's called a late stage fall response to minimize fall impact. We think it's real. We think it really can help. And then that's the grant. And here's some other devices you might want to think about, particularly for this cohort. Yeah. And then this is my clinic. And we had a physical therapist who was there with me. That doesn't work because Medicare quashed that. But I still worked with them, but not in the clinic. Social work sometimes is called. We do a comprehensive assessment treatment, further diagnostic referrals, medical recommendations, PT, recommendation for safety. And I told you, remember I told you about something that you guys should not be afraid of falling? What I meant was, if I teach you how to fall, in addition to you not being afraid of falling, the two back there who raise their hands, if you learn how to fall, then you really won't be afraid of falling. So it's coming. It's not there yet. It's still a research protocol. And if you forget what I just said, I convinced somebody to write an article about me about 7 years ago. It summarizes the whole thing. It's in Our magazine, carefully buried, like many of my articles are, carefully buried in the literature with low impact factors. Okay, I think that's it. Thank you. Questions? And again, a shameless plug for my clinic and a shameless plug for that article. And yeah, go ahead.
Well, the only question I had, more of a statement. When I was younger, I went through parachute landing falls. And so it sounded like your training of doing the kind of thing how you fall, so you don't jam your legs up.
So I have a clinic at the VA, which I keep under wraps because I don't want to be inundated, because I already have a clinic at the university where I'm inundated. And that's exactly what I did. I started asking the guys, were you in paratrooper training? Were you airborne? Were you in airborne training? Some of the Vietnam vets were jumping out of helicopters, but it's surprising how few there were. But if you ask a Parkinson's patient who's not banged up too badly, they know how to fall. Somebody who falls all the time knows how to fall. Because if they didn't, they would stop falling for other reasons. Yes, good comment, thank you.
I think something that's real significant is height loss. That personally, it came on real slow, and then all of a sudden I said, "There's something not right," And so I said, I worked in a clinic. I go, "Can somebody measure my height?" And I'd lost 2 inches.
Yeah.
And so I think that's a problem too with balance, and just strange thing that happens with people.
Thank you for bringing that up. So I have a couple things to say about that. First of all, and I do yoga all the time, and I see myself in pictures like this. Can you see me? Sometimes I'm in pictures, I'm like this. I'm like, what are you doing? So I do a lot of work, like just kind of, put your head up, put your neck up. Some of what you're describing is kyphosis, probably from intervertebral disc narrowing, maybe even some vertebral bone loss and bone breakage, which is osteoporosis. And we actually did a biomechanical evaluation. We never published it, though, that you'll see people like this. And what happens is eventually, once it starts, because when you're in your full alignment, you're good. But once you start doing this, you have 16, 17 hours of gravity working on you. And it's impossible to, we have kind of things like to put your arms back. Anyway, the head actually weighs, let's say, 10 pounds, and you might think it changes your balance. The movement of your center of force or center of reaction is not that much. But I think what the issue is, you're not scanning your environment as well anymore because you're looking like this.
Especially when I'm on a ladder.
Oh. Say no more. You know what I'm going to say about ladders. Any other questions? Yes.
How about using those walking sticks?
Okay, so I mentioned briefly about assisted devices, and I think we've. I want my patients to take on anything. Some are going to need a walker. Some need a cane, but if they need a cane, they probably can get away with a walking stick. And I send my people to outdoor stores to get a walking stick, and either one or two, to be used when you're going to be you're going to be walking a longer distance, and particularly with hazardous terrain like a squishy surface like sand or grass, uneven surfaces like the sidewalks in Ann Arbor. Okay, so a total fan of it, and I think older adults don't feel the stigma of a walking stick as much as a cane. Let me say one more thing about a cane. So I have patients who have like a bad hip or a bad knee or something, so they need to unweight. It's you put in the contralateral hand. It's the hand opposite the bad leg. So I think that's not a walking stick treatment. That's a cane treatment. But if you're using it, a lot of people I see kind of like carrying their cane or like touching it periodically. The cane carriers, you know who you are, and that's okay. Because maybe you don't feel as steady, you're a walking stick candidate. Anything else?
Jim, are there any questions online? No? Okay.
Oh, my clinic is at Turner Geriatrics Clinic, the one on East Ann Arbor. I like to say, bring me your tired, your poor, your falling masses yearning to be upright. Okay, thanks a lot, you guys. Okay.